And as you said very correctly, Dr. Haripriya and Arvind Eye Institute study is very, very encouraging for moxifloxacin, but probably their number of surgeons, the type of surgeon, the quality of surgery, and the volume is a reason in which probably moxifloxacin will definitely give a positive result. But the patient, the institutes or the place like us where the number of surgery is not that much, we can control the quality of the theater, ambience, the surgical skill of the surgeons used who are doing less number of surgery are very, very good. So probably moxifloxacin will take a long time to prove its efficacy. I'm not against using it, but I feel definitely it is not very much required. And another reason which is coming that right now moxifloxacin, if you talk about the other things, for DCGI approval kind of thing may also become an issue. So those who want it can use it, and particularly in some cases they can start. But my take, one point I want to say that whenever you inject moxifloxacin at the end, very end of the surgery, you actually open a section and you want to inject something for which you press the lip of the section, which may itself be a reason for ingress of organism. So I want to seal the wound very tightly. Even at the cost, suppose wound is not getting tightly sealed, then you can do a more hydro in which the corneal edema or the corneal whitening may be visible to a large area. But tightness of the wound is very, very essential. And now I am giving Dr. Ankur to present the slides for the second case. And the very important point you should see is the topography. Very high cylinder, very regular cylinder. Many of the patients who have a high cylinder like this usually have a keratoconus or something, but she does not have any of corneal pathology. And we have done serial topographies and pentacam, and all of the work have shown a very regular and consistent kind of result. Yeah, please continue.
Thank you, sir. This is the patient with regular astigmatism. Corneal astigmatism is around 3 diopters, and as you see, you can see in this topography picture. And this is a pentagram of the same eye. We are doing the left eye, and we'll be implanting this Toric IOL ZCT 450 at 7 with 7 diopters of power. And this is the calculation sheet which we get online, and we'll be implanting it at actual 68 degrees. So marking was done previously on slit lamp, and Dr. Virendra will take over. Thank you.
नहीं क्या बोल रहे हो उसमें हाँ लास्ट लाइट थोड़ी सी रहेगी है ना थैंक यू अंकुर दिस इज अ केस ऑफ हाई मायोपिया सो विल बी कीपिंग द पैरामीटर्स ऑन अ लोअर साइड लाइट के बीचों बीच देखना है लाइट के बीचों बीच देखना है we are lucky to have Callisto, so we prefer to use Callisto, but I am thankful to Dr. Amit Mishra for giving me the manual marking for this patient. I just wanted to highlight the toric lens is a time required that whenever there is a cylindrical number of importance, you feel everybody is now having a different cutoff value. My cutoff value initially was 1.5 diopter, but now I have come down to 0.8 plus diopter. So diopter is more than 0.8 when we implant toric lens. लाइट के बीचों में देखना है कश्मीर जी लाइट के बीचों में देखना है What is axis placement? IOL axis placement.
Sheet पे होगा ना?
Can we get the? We are getting it in the panel. Can we get the microscope view alone? Gaurav.
TIP को बंद करो. TIP को बंद करो.
Gaurav, it is coming as a panel. You know, we want the microscope view.
लाइट के बीचों में देखो. Right now, are you getting microscope view?
No, just 1 second. Jaswinder ji, can you just sort this out?
Doing it.
It is coming as a gallery.
Yeah, it's okay now.
Okay,
I
it's
think.
okay now. Yes. It's okay. Yes, you can continue.
Thank you. Thank you. So before marking, the cornea should be relatively dry. If it is a wet cornea, then you will not be able to have it. The issues with high myopia, toric placement, that at the end of the surgery, when you actually want to really align it, it is difficult because the eyes are slightly bigger, but I will try my best. लाइट लगा दी इसमें। देखो रश्मि, लाइट के बीचों बीच देखो, ऊपर थोड़ा सा और ऊपर, हाँ ऊपर देखते रहो आप, बीच में हिलो नहीं। 68 ना, लाइट के बीच में देखना है। इसमें ये कोई दर्द नहीं होगा, दोनों आँख खोल के लाइट के बीच में देखते रहना है आपको। चलाएं। The glow is very clear, but I just want to show that I prefer to use dye, particularly in patients where I want some other help. In that case, the last case was in some of the areas where the glow was not very clear, but we could complete the axis, but then we aim for a very small axis. लाइट के बीच में देखो, आप नीचे देखते हो ना, ठीक नहीं है, हाँ लाइट में देखते रहो। Everybody should know, those who are doing toric lenses, their SIA or centroid for having better results. We are using Barrett toric calculator and supported by the company calculator also for better outcome. Wherever there is a discrepancy for some reason, then we do recalculations, and that recalculation means total complete biometry including corneal workup is done for having the better results.
I think, Virendra, it is a good idea to always manually also mark, even if you have callisto, because
Yeah.
Sometimes
in that case, what we are doing, you are right. In that case, what we are doing is that we are marking callisto mark on the cornea in the table itself, on the table itself.
Okay.
Not doing pre-operative marking.
Yeah.
But if during the start of case we don't get a marking on that case, then we take them back again for marking manual, and then only we start. Here, I would like to share my experience with the eye trace, that what you can do is, you do a mark, preferably as you do 180/90, and then take that picture on eye trace and have that picture in OT to help for further accuracy. Light के बीच में देखते हैं।
So the advantage of callisto is also it tells you where you should make your incisions, the main and the side ports. It gives you that, and also gives you the capsular axis. Of course, Virendra's capsular axis is so good; it's beating even a femtocapsular axis. But in terms of size and the centricity, one can also, centralize the capsular axis completely on the center of the cornea. So
another thing I want to just point out, that before doing hydro, always check the syringe having a good gush or not. Sometimes what happens, there is a blockage somewhere, because we get them cannula reused by autoclave, and there can be an issue that when you want to do, you will not get flow enough. This is a high myopia, slightly overfluid wave.
So I think what is the power of the lens was 6 diopters with the cylinder?
7.
7 diopters. So I think all the features of high myopia we should expect in this case. The red glow was appearing to be very good initially, but now as we do the case, I'm sure we'll realize that, the cataract is harder, which is again a feature of high myop.
कृष्ण जी आराम से हैं, बीच में हिलना नहीं है।
I think this intuitive machine has a very good, is very controlled kind of a machine with hardly any search. This is intuitive also again, Virendra?
No, this time we are doing on this machine, Signature Pro.
Okay.
The first case was on Intuitive.
Okay. So this is Signature Pro, which is the panel of which can be seen here.
Yeah, this is a high myo. So I am keeping a bottle light very low.
So again, very useful to keep the bottle light low in the high myopes, because sometimes what can happen is that if the zonules are weak, the fluid can seep down and then you can have an erroneously shallow AC. And as it is, they have a breathing kind of a pupil which will, which will become mid dilated and will keep dilating in between. This fortunately is a good case, and so that phenomena of iris diaphragm, that retropulsion syndrome, is not occurring here. But notice that the glow was appearing to be very clear, and now actually it is hard in the center. It's not a soft cataract.
Yeah, this is a nuclear cataract.
Yeah.
So the nuclear sclerosis, and she was a high myopia, and now the myopic power has increased to minus 22 or so, and that's why she has come to us that my power is increasing.
So this is being done under topical anesthesia.
This is under topical anesthesia, but you are rightly pointing out that preferably such patients can be taken into block. The only issue that high myop, the chances of having block problems, perforations, cornea saline डालना, are slightly higher.
Yeah, so it is it is better that you do it under. I mean, it is good that it is being done under topical anesthesia.
This only was a part of nucleus kind of thing, so I am just removing first that, and then I will shift to vacuum settings. रश्मि जी हिलो नहीं, आंख में जोर डालने की कोशिश मत करो. चलाएं.
So
It was
again,
not having a free dissection, so it was not easy to rotate. So I'm not rotating much. I'm just shifting here and there and try to take it out. And now I'm through. So whenever there is not an easy dissection, you should not use, should not be in hurry. Keep patience and then you can complete. The signature is having automated bottle height adjustment. So the moment I shifted from FECO to IA, again the bottle has increased. So I again lowered it down. And as Dr. Mamta has really pointed out that you should not have a deepening of the NPH chamber and with the in and out movement. So that prevents the donesis part and prevents the complications in the later time.
so Virendra, you're using irrigation aspiration. Which company is it, and what is the gauge? I mean, you don't have to extend the incisions. Otherwise, in some of the irrigation aspiration probes, you have to increase your side port a little bit. So this you are doing very efficiently and very nicely. We can see each and every fiber, getting aspirated. I
These
think.
are manufactured by Epsilon, and I'm happy that we advise them something for the angulation part, the curvature, the length, and the sizing. So they go through the MBR opening of 19 and 20, both sizes are available. and I prefer to use having a diamond dusting on both and irrigation line and aspiration line, and with this we can remove these fibers very easily. All the fibers are not to be possible removed by just aspiration port, so I use the irrigation port also for doing removal of the fibers by just doing a gentle polish over the fibers, and then you can aspirate them out. So this you can see that I am trying to remove with the aspiration port, and then I will show you that how we can use the irrigation port. This irrigation port you can just do a kind of polishing massage over the fibers where they are, and they get loosened, and then they can be aspirated easily. And using the bimanual that you have access to 360 degree is a big advantage.
I think
You
that
can
is
see that half is almost cleaned up, and now I'll be shifting it to the other side.
I think that is a very useful tip, that the irrigation probe itself can be used, for used as a polisher for the little bit of fragments of
You
cotton.
can see that how effectively it do. That aspiration port was doing it slower. The aspiration makes slower, but irrigation makes it faster.
Yeah.
Because that irrigation itself is having a one of the pressure, and here I am keeping the same parameters as I do for cortex aspiration or for visco removal. So there is no change of parameters required, as other people are using that. When you use aspiration port for removal of the fibers, you need to reduce vacuum to almost 0 or 5 or 10, because otherwise it will suck or hold the capsule. But here there is no risk of holding the capsule by this means, so that is a big advantage. And you can remove all fibers. So I have done the almost central cleaning. The peripheral part I will again use the aspirate part to go underneath the capsule and remove. You see that I could hold the capsule, so that is not good for safety, but aspiration mode gives you that comfort and safety. रश्मि जी बढ़िया चल रहा है, लाइट में देखते रहिए। हाँ, सीधा ऊपर ही रखिए नजर को। Are you all ready? चलाएं चलाएं। As we were discussing in the last case, that posterior capsule opacification and preservation of posterior capsule is very, very important, particularly in this patient where it is a high myope. So there is also an issue that polishing practice is going to be helpful.
Oh, high myopes.
So my advice is that do polishing in all patients. So in case of the complication or a difficult case, also you are comfortable in doing.
High myopes also tend to have cataract at a younger age, so it is best to polish them more so that they don't have a posterior capsular opacification.
हिलना नहीं है, थोड़ा सा कुछ होगा, लाइट में देखते रहना है।
So this is Technis Toric intraocular lens.
This is Technis Toric. So the advantage of porosity on a very trusted platform of Technis is there. And removal of the visco behind the eyelid is very, very important. in all patients, particularly to prevent PC also, but for toric lens to keep the lens in place, not having rotation on a visco bed, the complete visco removal is a must. So I am doing the visco aspiration behind the IOL first. Centered है ना?
It is perfectly centered.
Thank you. Thank you. And you can see now I am using the different bimanual aspiration cannulas, again made from the epsilon, and they are non-polisher. So at the beginning I use polished cannula, and after lens I do non-polished cannula to prevent the any damage on the IOL. So I can go freely, confidently behind the IOL and rub off even the surface of the IOL to remove all visco. So I am just using the irrigation line behind the IOL to any sticked visco on the surface, and then at the end I will remove the NTA chamber IOL, and then I will do final placement. Final placement in high myop is sometimes very risky, very difficult, because the patient's eye, when you actually seal them up, the IOL tries to rotate.
So I think it looks absolutely crystal clear. The lens is shining, the glow is so good, and the capsule
बीच में
is so well.
बस रश्मि जी हिलना नहीं है, दोनों आँख खोल कर रखना है, लाइट के बीच में देखना है. बिल्कुल लाइट के सेंटर में रखना है अपना, लेंस का फाइनल प्लेसमेंट करना है, आपको हिलना नहीं है.
So, Dr. Virendra, your this thing placement has to be done. Okay. I was just thinking that are we closing the case, and I was about to, point out. So the placement you do, it's done more with the BSS. Using the BSS, you just very gently rotate it to the axis, desired axis.
Yeah. And this what I am doing, the final closure like this is giving me a total control on the pressure. I see that any aggressive fluid is there, and you can see the alignment is well done.
Yeah. Perfect alignment.
Light के बीच में भी देखो, is coming there. The marks are visible.
Yes, yes, very nicely visible.
Or is it become better now?
It's become much better now. With the retro, it is much better. But we can see otherwise also without the retro.
Thank you. रश्मि जी बढ़िया हो गया आपका, दोनों आँख खोल के रखना है. आँख बंद करो, खोलो, खोलो, आँख खोलो. At the end, I see that any ingress is there or not there, and the placement is still on the place or not. बंद कर लो आँख, बंद कर लो.
So it is generally said that the maximum rotations of the toric IOLs, if at all they have to